a little bit of a sort of a run through some of the studies that we're doing, and the intent is really, I think all of us have spun it in terms of what does it mean to the community, what does it mean to potential stakeholders. So we're presenting our research project in a maximum of 4 minutes. So it's 3 minutes, we'd like 4 minutes, we are literally cutting you. So I'll let you know if there's a minute left, so you make sure you wrap up before that. And we're not presenting to a scientific audience, we're presenting to a lay audience. The intent is, why would you be interested in our work, okay? And so the first speaker is going to be Andrea Parna, who is the coordinator for the project, and she's going to present on our behalf.
Okay, so I'm going to be talking about the access to resources in the community study, ARC for short. The objective of this study is to improve equitable access to community resources among vulnerable populations. So the objective stems from extensive consultative work that was done with key stakeholders in the region, particularly healthcare providers and patient representatives, who identified a barrier to access to resources in the community as a priority need to address unmet health needs among vulnerable populations. So particularly individuals that could benefit the most from these health-enabling resources, a breadth of them including smoking cessation, diabetes education, falls prevention, mental health counseling, often experience complex social barriers that limit their access to these resources. So what is the solution? Again, through consultative work, key stakeholders identified a patient navigator intervention as the ideal approach to support vulnerable populations overcome barriers to access and reach these resources. So there are patient navigators in the community already. For example, navigators that support disease-specific populations such as cancer patients achieve these resources. But what's really innovative about the ARC patient navigator intervention is that it is integrated in primary care and supports a broader vulnerable patient population. So the navigator meets with patients at the primary care practice and is able to communicate directly with their providers to support better care coordination and continuity of care between primary and community care. So far we have approximately 70 patients enrolled in the study, and some preliminary finding indicates that about 70% of these patients identified 2 or more resources that would be beneficial to them to access in the community. And the most common resources relate to healthy lifestyle, mental health and addiction, and financial assistance, amongst others. And also interestingly is that for all patients who've met with the navigator, so about 80% have identified at least 2 or more barriers to accessing these resources. And the most common barriers identified relate to knowledge, so awareness of resources in the community, emotional barriers such as confidence and motivation in accessing a resource, and financial barriers. So amongst many things, the activities that the navigators will conduct in order to support these patients overcome barriers and access resources revolves primarily around providing emotional support to patients, contacting resource staff to determine eligibility criteria or whether or not additional application or information is required, and researching new resources that really take into consideration the barriers that the patient encounters towards being able to access a resource that can help them achieve their health goals. So far, 47 people have completed navigation services within the study, and amongst these people, 43% of them have accessed at least one resource in the community that they've been referred to. And here are some quotes of these patients' experience with the navigator. So overwhelmingly positive. People are really feeling supported and feel that the information and the services that are provided to them are really helping them achieve their goals.
What, is there not another slide? No?
No. Sorry.
Okay, great. Thank you. So that was 3.5 minutes. Thank you.
Okay, so take a little different approach. What I'm going to tell you is just our program of research and our approach, and some examples of of the sequential projects that we have in our program of research. No conflicts of interest. So we have. I'm going to talk about 5 areas in our program of research. So we have a lot of research projects on health services at the end of life. So I'm part of the division of child care now. So we look at how is care delivered at the end of life, and what's the effectiveness of that care. Part of the end of life, obviously we look at people with dementia, so we have a few grants on dementia, looking at risk factors for development of dementia, and then looking at what are the predictors of transitions between care needs. People with dementia, obviously, a lot of them require long-term care, so including QUILT, we have a few projects, few grants on nursing homes and meeting people's long-term care needs. We have a whole series of projects if people are interested in any of these sub-projects on end-of-life subpopulations, pediatric populations with HIV, COPD, the list goes on. And I think a big part, and the last thing is a big part of what we do is risk prognostication, and so we have that RISPECT tool that it's almost like a key conduit for our algorithms that we build. And we do some performance measurement for the province. So the typical, just like in grants, the typical process in our program of research is descriptive, and then more intervention and then evaluative. So this was, I'm going to pull a few media stories. So this was our first descriptive, for example, for our first program of research, first descriptive project looking at end-of-life healthcare use and costs. So we just described the lay of the land. The second thing, what we did is we looked at interventions that can improve some of those outcomes. So in this case, we looked at palliative care, how care delivered, who is it delivered to, and then the third series of projects that we normally do is tying them together. So how's that palliative care impact our first descriptive paper, our outcomes? And so this was a paper that looked at that we just got recently in media attention, looking at physician-based home care and the effect of location of death, which we looked at in our first paper. So that's typically our progression. And so we do this cookie cutter approach in most of our programs of research. This one example in nursing homes for our second or third program of research. This was the first descriptive paper which got a lot of controversial press looking at for-profits and not-for-profit nursing homes in Ontario. So we describe it. Now we're looking at some of the interventions that can improve some of those outcomes that we looked at here, so hospitalizations and mortality. So we have a survey with Dan Kopikwa and others, and we have the QUILT grants to look at more of those interventions on how to improve some of these outcomes that we looked at in our first paper. And that's it.
Thank you. Great. 3 minutes.
So for those who don't know me, I'm Camilla Crumbs. I'm a family doctor in the community, and I recently completed my Clinician Scholars Fellowship here, and I'm continuing to truck along in my very protracted PhD. So what I've been working on for the past few years has been primarily centered around access to primary care. I don't have conflicts of interest to disclose, but I have thank yous to declare. So to most of the people in this room who provided me with a lot of mentorship and support and have been very generous with their time as I've been plugging away at this work. Thank you. So access to primary care we know is important at both the patient level and the health system level. We also know that certain vulnerable populations face increased challenges accessing primary care. So we know that this is an important aspect of primary care to address. We also know that based on the Commonwealth Fund study and data from Health Poly Ontario, that Ontario and Canada as a whole seems to perform quite poorly in terms of access to primary care compared to other developed settings. But are we asking the right questions when we talk about access to primary care? So the Commonwealth study and Health Quality Ontario evaluate access to primary care based primarily on the metric of same-day, next-day access. But we know that access is much more complicated than that. There are many dimensions and definitions of access in the literature. So I'm going to talk about 2 ways we're looking at access right now. So one is a recently completed study on access to primary care using a more multidimensional approach, and the other is looking at how access is being rewarded at a policy level in Ontario. So the first study, we took a multidimensional approach to understanding access. We used the Qualico PC patient experiences data set for Ontario to study 11 dimensions of access to primary care. And we found, interestingly, that when we look at access in this more multidimensional, comprehensive approach, patients actually feel quite positively about their access to primary care. Now, these are patients who are attached to a practice, so you cannot apply this to patients who do not have any access or any attachment to a doctor or a practice. But when we looked at the 11 dimensions as a composite access score, with the highest possible score being 2, the mean score was 1.78. And when we looked at the individual items, Even though 68% waited more than a day for their appointment, the majority, 96%, said that it was easy to obtain their appointment, and also the majority, 87%, said they got their appointment as soon as they wanted to. So that highlighted for us that perhaps looking at the metric of same day, next day is a bit too narrow, and maybe the timeliness of the appointment and the acceptability of that time, elapsed time of the appointment date, is more important to look at when we're evaluating access to primary care. So this is coming out next month in CFP, and collaborators on this project were Bruyère out of Western, Bill Hogg, and Walter Richis. So up next is looking at access and pay for performance. So pay for performance is increasingly prevalent in healthcare. Pay for performance means financially rewarding certain processes or behaviors or outcomes. And in Ontario, we have a pay for performance incentive around access called the access bonus, where practices whose patients seek less walk-in clinic use are given a bonus payment. But there are a lot of criticisms of financial incentives in healthcare, including unintended negative consequences and poor evidence that it actually works to improve quality of care. And there's also criticisms of the access bonus in particular, in that you cannot force your patient to go to their own family doctor. They have choice in our healthcare system. Physician factors, if you live in a small town and there is no walk-in clinic anywhere, you're going to get your bonus. So it's difficult to know if we're actually rewarding access from this access bonus, and over $200 million has been spent on this bonus payment so far. So we are going to look at that same Qualico PC patient experiences data set to look at patient-reported access to primary care, and look at the health administration data from ISIS and see if there actually is a correlation between high access bonus achieving practices and patient-reported access.
Thank you. Okay. Is that the four? That's the four. Okay, perfect. No, one more. Ah.
Okay. I don't know if people have been following the shooting in Florida, and I guess the youth crusade against guns. And I think I just heard something on the radio coming in today, and it was so inspiring to hear multiple youth speaking out against an injustice. So I think we're going to be using that kind of motivation as we take on homelessness in vulnerable populations, and what I'm calling the 50-50-50 challenge. So this situation, the government has promised $40 to $50 billion to look after housing for Canada. This will reduce the chronic homelessness by 50%, and this includes 500,000 vulnerable families. And the exciting part for us is that this will bring a lot of people back to family practices. So there's currently up to 300,000 people on the street, and I say conservatively 50 to 100,000 homeless people that will need a family practice. And will we be ready? Will we be ready? And that's what we're working on, is the Canadian evidence-based CMAJ guidelines, but that's of course not enough. So you need, what we want to do is do a national center of excellence on homelessness and vulnerable populations to use our systematic reviews in Campbell. I just want to recognize this is from the Bruyère Gallery, one of the artists. And so this housing, that's from Housing First, but we have interventions that are up to 80% effective. So it's really exciting that there are actually a lot of things that can be done, and I believe Canada and our partners, including us, are ready to do something here. I'm not going to really give you the details, but I think it's exciting for us, and I know Claire really gets credit for bringing up the idea of a Center of Excellence, so I thought, okay, yeah, let's try this. We should be thinking that we want to do Centers of Excellence, and we have to think how we're going to do this. And I do think we have a lot of these ingredients already in place, but I'm not going to spend too much time going through them. Just to say that we would work with 3IE from, I gotta email them, but from the UK and some of their new stakeholder analysis, which we're already starting to use for our project. Work with the Cochrane and Campbell Equity Methods Group, the Campbell Collaboration Journal, and a number of different partners. And we will be producing systematic reviews. We have, I think, 3 on the go right now already. We have a CMAJ already committed to publishing our guidelines. We have equity gap maps. We have 1 funded by the government, but several. We hope to do more once we get the first prototype done on women. women interventions, and that's happening through a Montreal group. Then there's the Public Health Agency of Canada has been giving us full support. I met with Teresa Tam and about 6 other people, and they see that we are kind of one of the ingredients that the government needs to move forward their agenda on both vulnerable people, Indigenous people, women, and youth. And the thing that we have that I think is really unique is we had 76 people from living vulnerably or homeless on the street that gave us feedback into what was needed for our work. And that's from across Canada. 10 different organizations helped us get those people. We have 2 of those people working as almost collaborators on our team. We call them community scholar. Claire Kendall had come up with this concept, and I think it's going really well. And so they are really fired up about the idea of a center and being a part of it. And part of this center is to have the users, the real users, just the patients, involved from the beginning. And I was really worried about the 1.4 million I need to raise, but then I thought I can go to Bruyère and they'll help with that. But actually, St. Mike's maybe. But then I realized, then Terry and Christine were just so nonchalant. They just said, "There's no problem, Kevin. We got the network. We'll panhandle. We'll send out the forces." And they said this, and I can't really do that like they can, of course, but in such a positive way. And I really enjoyed hearing their voice and saying, "We are with you, and we're all with you. We don't want to be on the street, and we're gonna work to get off the street too." So that's, and then we have we have lots of other partners that are signed on. A lot of them committing money already. So I think we're in good shape to do something. And whether or not we get the center, I don't know if it matters, because I just want to say, as you develop something, you actually improve your team. And so we don't really need to get this grant. At the end of the process, we're going to have a stronger center, whether or not it's a national center or not. But in the future, I hope that this is the kind of things that we'll succeed on. But there's only 3 in the country, so I realize the odds are tricky.
Thank you.
Okay.
We're way past. Thank you.
Okay.
Okay, so we've got 10, well, maybe 7 minutes for discussion. So I don't know, do the folks who presented want to be at the front? Yeah, maybe that's a good idea. And so maybe Kevin, Peter, yeah, that's great. And I don't know if we'll give the honor to our guests today in terms of asking questions, whether it's clarification or if you have ideas. Or
How do you enroll patients in your project? So it's essentially via provider referrals. So we have participating practices and providers that have consented to participate in the study. They feel that one of their patients could benefit from a community resource rather than just entering it in the chart as a recommendation. We've designed a referral form for them to fill out. We get a copy of this form, the patient gets a copy, they keep a copy, and we contact the patient to then explain the study and recruit.
It's your specific question, we're not in Bruyère. Because you have the Social Accountability Initiative.
Yeah.
We were intended to be at Bruyère, but because Mike's project's there, it would be a bit competing. So we are at another.
But community physicians get patients too.
Well, we've recruited, we've got 4 practices.
Right.
And we're at the end of the feasibility, but we're going to have a randomized controlled trial, and we're going to be in the Francophone region. So it's going to be community and practices, but more in the East End of the
So if I was going to ask how to tie, is there a way to tie all these together somehow? Is there a way to put Peter's drawing and your drawings and things to sort of say, here's what we're all looking at, and here are some of the things that we're all, you're not collaborating together, but that somehow link projects, or are they very distinct from each other? It's probably a naive question, like,
No, I
do you see some
definitely-
integration?
Oh
or
yeah,
some-
like service care delivery for sure is a common link, I think, between
equity.
for equity,
I was
vulnerable
gonna say
populations.
equity.
Like,
Yeah.
for me, I feel like there's this whole piece around equity that, as an organization, that's always been kind of one of the pillars, and certainly even like reaching as far back as when Mother Bruyère kind of came to what it wasn't even Ottawa, And I think it was just, like, I think it's February 20th, so it's literally this month that there's an anniversary of that. And I think that as an organization, we actually need to own that a little bit more prominently and kind of,
I
you know,
absolutely agree. I think it's Bruyère continuing care. We are there at every stage.
Yeah.
Look at that. We
Yeah.
are there with excellence at every stage.
that's right, that's right.
So, I mean, your question probably is intended for like the broader group, and so maybe we can reflect on it again. But definitely when we've discussed it as a group, equity was one thing. And depending on how you define access, I think you'll find a lot of our work is access-based. So access to appropriate end-of-life care, access to appropriate services or social resources for the vulnerable, community resources, primary care.
Yeah, I would take a little different perspective on this, is that and we haven't really done this very well, in my opinion. We've done a little bit, so it's how do we actually kind of move forward more together, taking advantage of what we're learning and linking elements from equity. But I mean, palliative care came up. I just barely missed our priority topics. We know that palliative care in homeless is a gigantic thing. We just had, we just followed a process and it didn't make our top list. But for instance, in the future, we know what needs to be done. We know that there's stuff, it was Lamont's project that's kind of related. So I guess I just don't know if we've ever had this ability to kind of to be planning for the future grants or the future whatever, because I don't think we can go backwards. It's like, we can't make things fit like this, the round pegs and the square holes. But we're not actually that different. So I think we've done this. I think a little bit, Simon, with your team grant, so you did this. But I just think we really got to be always thinking, how do we get ready for the next thing on the equity? I don't know if equity has to be operationalized, and that's all I do is equity. But I see it doesn't necessarily fly very well without operational elements, because it can be very. You can debate the whole concept all the time and never do anything.
But
So
I think, there's an opportunity right now for Bruyère because there are three new kind of heads of the organization, right? Myself and Guy and Heidi in this acting role, and they're both like, so we are actually going to embark as an organization. I feel like I'm back to the
Sorry, yeah, no, that's good.
I fell on the ice. I'm really sore. I fell on the ice on Tuesday. So I feel like there's this huge opportunity for us to re-envision ourselves. So building on all of the great things that we're doing, but thinking really in terms of 10, 20 years and what's our real contribution in the system, kind of owning that post-acute space from a delivery model, and then re-envisioning, because a lot of it is there, we just don't talk about it the right way, right? And so how do we really kind of put a stake in the ground as far as who we are and how we do what we do? Like, I think a lot of the work that PRI is really excelling in is that system level analysis. So like learning from the populations that we serve, but then applying that to the broader kind of system piece, which I think is such an important contribution. So there is an opportunity within the next 10 months. We're actually going to be embarking on a big strat plan, and I know, like, historically there's been a lot of attempts as an organization, but I think timing-wise and opportunity-wise, there's some really great things, and I think it really has to be an integrated strat plan in that, we're an academic health science center, and I think, in the past we've been kind of three siloed organizations as opposed to, really thinking about what does that actually mean from how you build your clinical services to, like, and I think, our family health teams have done an incredible job at that, and the rest of the organization could actually learn from those approaches, right? I think PAL has too, but so I just feel like as an organization, we need to, and you should all be thinking about that, right? Like, how do you fit, making sure that we're aware on the hospital side of what you're doing, and that we do make a better job of kind of building those connections and bridges.
So today was sort of the first, the encounter, but I'm wondering about whether it would be helpful for us to have a facilitated discussion. So today you'll get kind of like, rapid shots, but to
I'd like
work
to see some
together.
money put down on forward thinking and getting us moving. So I really want to sit down and discuss. I want you to put some money on the table so that we can, like, everybody can have an opportunity to move forward. Like we did this at IPH about 10 years ago, and it was actually quite successful. And of course, fortunately, we lost our directors and stuff. But I just think that discussion is nice, but actually they put money for small projects, and they said we want you to work together on these concepts. And it
And I think that
doesn't
we'll
cost
need to
that
have
much
a
money, but
discussion for you to understand how you can best.
and it allows other
support
people
So-
to join. Like that's the other thing, is that like Risa's getting into research. I noticed she's here every week. But so I think the idea is letting we have people that aren't in our projects now that I'd like to be able to have an opportunity to join new ones. So when you have a new thing happening, you let new people in, whereas we could like, you know,
We're gonna have to
monopolize
move on.
the.
Yeah.
This is a
One
problem.
last-
It could be a problem that the old people kind of like me don't let new people
We
in.
can have it broadly open primary care. Last
Just from the perspective of a clinician teacher, we are educating our future primary care providers, and I don't see as much of that support for those of us who are doing the academic teaching. And I'm just wondering if then also, you know, I mean, gosh, I'm so impressed by all these projects, but at the same time, in order for us to pass on the skill, we need to support
It's an area we
as
need
an
to develop.
institution.
So I'm going to stop the discussion here because we'll have more opportunity after we've heard the next one. So Iman, can you tell us how they're ordered? Because here we are. Okay, so Doug, Sharon, Claire, and Claire. Okay, good to go? Pardon?
Or the same thing.
Oh, there's 4 more? Yeah, and then we can have that broader discussion.
So, for Dr. Archibald, it's a video, it's a 3-minute video, and
Well, that's nice.
Clever.
We'll see.
These are the educational people that don't present to us. Yeah, exactly. They don't present.
Try new things.
Olympic highlights of it.
Not last night.
Not last night.
Oh.
First thing my kids asked me. This almost is heartbreaking. Did he win? Teaching.
Hello, my name is Doug Archibald, and I'm an assistant professor and PhD education researcher with the Department of Family Medicine at the University of Ottawa. I'm cross-appointed to the Department of Innovation and Medical Education and also the Faculty of Education. I'm also an investigator with the Bruyère Research Institute, an affiliate investigator with the Clinical Epidemiology Program at the Ottawa Hospital Research Institute. My main program of research is about how we use technology to best support learning. In Faculty of Education at the University of Ottawa, I teach several courses on healthcare education technology and integrating technology into teaching. In the next few minutes, I will outline a couple of projects and identify the impact they may have for clinicians and patients. First, I'm leading an international project to develop reflective learning and feedback instruments for clinicians who use electronic consultation platforms. The idea here is that primary care providers and specialists learn something new every time they complete a consult. The instruments take them through a systematic method for documenting their learning that will lead to professional development points or maintenance of certification provided by accreditation bodies in the United States and Canada. Furthermore, these instruments will become valuable tools for primary care providers to give feedback to specialists on their clinical responses, and for specialists to find out the outcome of patients they may never see, if a face-to-face referral is avoided. Mobile, or M-learning, is a facet of electronic learning that is growing exponentially. A number of years ago, I led the development of a tool called the Interprofessional Collaborative Competency Attainment Survey to assess interdisciplinary healthcare programs. This has led to partnership and collaborative research activities with the University of Minnesota and the National Center for Interprofessional Practice and Education. On the website, you'll be able to find the survey and webinars of how to use it for program evaluation, anytime, any place. At least 40 programs are using the survey, including the Dalhousie University Preceptor e-learning course, University of Georgia College of Pharmacy, University of Kansas Medical Center, Indiana University School of Medicine, Fort Wayne, and the Purdue School of Nursing, just to name a few. Together with Dr. Veronique French-Merkley, I co-led the development of a series of e-learning modules on patient safety and quality of care for Bruyère continuing care, staff physicians, and residents in training. These are publicly available for learning anytime, anywhere. So what's the impact of this work? Well, it gets clinicians learning from each other, either in real time or asynchronously. My research is about creating communities of learning that may not have existed before. It is my hope that when clinicians have better means and methods for learning, this will translate into better care for patients.
Nice. Okay, who's up after Sharon? Yeah.
I was about to say this is my training in speed dating, and then that kind of like put like a pause. That's the whole movie. Your husband or spouse or whatever. So in my 3 minutes, I wanted to tell you briefly about the transformation research program that I'm leading with an amazing team across the country, whose focus is to understand how we should measure primary care performance, to understand it and report it, especially to policymakers and Canadians. Figure out how to use this. There we go. Okay, why is this important? If you ask a group of people what makes a community a good place to live in, depending on your stage of life, you're going to say schools, safety, jobs, leisure activities, parks. If you ask them if they've moved to a community where they might not be able to get good primary care, for most Canadians, that would make it an undesirable place to live. Most Canadians expect good primary care in their community. Most Canadians don't think much more about it beyond that. Is that enough? Primary care is important. It matters to our communities. It matters to the overall cost of our health system, to life expectancy within the population. So is it enough that we're more or less satisfied and really think about it if there's a problem? My research question was to ask what Canadians want to know about primary care performance and why. So I met with groups of patients across the country, essentially locked them into small rooms, much smaller than this, and we hashed it out for a day. What's important to you about primary care? What do you want to see publicly reported, and what would you do with that information? Do people want to know about how their doctors compare to others? If any of you have driven across the United States, you cannot be on a highway for 10 minutes without seeing a billboard, our community hospital is #1 in the district. In the UK, you can Google your own practice and find out how they compare to a nearby practice or the national average on 99 different performance indicators, whether you're going to get good osteoporosis care there or a throat swab that's reported to you within 2 days. Is that what Canadians want? We actually found out that Canadians in general don't feel like they have a choice of primary care providers. So they're not as interested in rating their provider compared to someone else. If they see a bad rating, what are they going to do about it? Most people also said, if you have a GP, you're usually connected, and by GP also NP in these communities where we went to. They're already connected with it, and they put value on that relationship. Changing it really requires an effort, so they're less inclined to go shopping, comparative shopping, the way you would for a surgeon doing an ankle surgery for a one-off intervention. That's different from what we see in the United States. Do they want to know how their community is served? You bet. Canadians know that there's a difference across the country and how our health system performs. And importantly, they know it's publicly funded. And if they knew that their community was less well served than a nearby community, they would actually feel empowered to do something about it by lobbying their government. Again, very different from the models we're seeing in the United States and Canada about how Canadians want to understand their primary healthcare system. And then lastly, surprising for someone like me who's been caring for patients for more than a decade and has never put up a certificate on any wall that I've practiced in, Canadians want to know They want to be able to trust their providers, that they're up to date. They know healthcare knowledge changes, and they want to know that they're getting the best. They want to see some sort of reassurance about continuing medical or professional development. So Canadians want to know how their community is served. They don't really engage in active choice of providers at the primary care level, but they do want to trust their doctors and the system that regulates it. So how we collect information and report it to them needs to start better meeting the needs of Canadians, because primary care is important.
Wow.
Wow.
Right on.
All right.
Will I get a date?
I wish I thought of getting it done, but I work with Doug, so
Yeah,
I'm
that's
gonna
good.
get you to make a video for me. All right, so I'm Claire Liddy. I'm also a family doctor and health services researcher, and I'm gonna give you a little snapshot of 8 years now of work on the Champlain-Basie Consult Service. So big team, lots of funding. I'd like to acknowledge Bruyère, they are one of the funders. Yes, it is there. And I have no conflicts of interest to declare, and that has been very difficult in the world of working in technology. So what is the problem? The problem that we tackled was a problem of access. Canada now, even in the 2016 survey, if you ask people or ask their primary care doctors about, how long does it take them to see a specialist, and is access to specialist care a problem for them, and are they waiting? We're doing very badly. So we're at the bottom of the list in terms of the Commonwealth country, and anybody who has been referred for a non-urgent appointment or has a family member who's being referred would feel the pain of 6 months, 9 months, 1 year, 2 years. Sometimes I don't even refer to a certain specialty anymore because it's just ridiculous how long the wait is. So what did we do with colleagues? Created an e-consult service. It's basically allows me as your family doctor to communicate to any number of specialty groups and ask the question and potentially avoid your face-to-face referral, but at least get the response much more quickly than that several months wait. How does it work? Very, very simple. You go onto a portal, you log on. We have a huge drop-down list of specialty services that are available, 109 now, anything that you can imagine. And what we do is we ask the specialist who then answers to give us a reply within 1 week. So that's pretty great. You see me Monday, I do an e-consult for you. Usually I'm getting the response actually in 2 days. And then I'm going to phone you or call you back in as my patient to discuss the result with you. So where are we at? From really small project, just an idea off the side of a coffee cup and a napkin, we've now had 33,000 people who've had an e-consult. We're across multiple clinics, towns and cities in Ontario, and we've had increasing growth in terms of primary care engagement in our specialty groups, and that's in the Champlain region. What's really exciting, based on these results, so these are our main outcome results, they're remaining very static. So we have a median response of improved access in less than a day. 60% of the people who have e-consult do not require to go on to have a face-to-face visit. And in 4% of the cases, actually what we are doing is picking up where a referral should be made. So that's a real great patient safety sort of catch for family doctors and their patients. So the big sort of focus now is spread, scale, and sustainability. So our own Ministry of Health funded e-consult as a program in April 2017, and now we're also working with other provinces across Canada. So we're in Newfoundland, they've had 1,000 people who've had an e-consult on our service now. We're in Manitoba, we're in Quebec, and this has been through a combination of program level funding and then also multiple research grants. So we're really proud of that, and my program of research really is under an implementation framework now. It's about policy research, and it's about very practical tips, tools to essentially spread, scale, and e-health innovations such as e-consult. One of the most exciting things now that we're getting into, and it's actually been very neat, it's the long-term care. So that's very much coming back into the home of Bruyère, and we got a small amount of funding to look at referrals in long-term care homes, to try to implement e-consult in long-term care, to think about beyond your normal primary care provider referring to a specialty group, in the long-term care community, what else is needed, and can we do some adaptation? So that's what we're doing, and we're in some homes now in the Ottawa region, and we're going to be expanding, and we'll piggyback it onto the Ontario program implementation. We're also now newly partnered with Peter and his group on Quilt to actually look at the first question is, what's the current state of referrals in long-term care? What I carry in my mind as we're moving into this is the picture of the little old person who's being rolled into the Riverside Clinic, because that's where the ambulatory or outpatient clinic is in for Ottawa, and they're huddled under multiple sheets, and they're going for that face-to-face visit. So we want to try to avoid that where it is relevant and where it's important. So I'll stop there. Thank you.
Thank you. Are you presenting on behalf of Claire?
Oh, so Claire just sent me a text saying that she's delayed. So
Is anybody able to present on her behalf, or should we?
Yeah.
Okay, sorry? Yeah. We'll do Q&A.
Okay. We'll just do, I think we'll, do you want me to?
If you
I have
keep
no
it
idea what the
quickly,
slides are, but
why don't
okay.
you put it
Yeah,
up
so,
there,
okay, yeah, Claire Kendall and I are doing actually a collaborative program of research called the Live Innovation Team. So that's advancing primary healthcare for people living with HIV. This is a 5-year community-based primary healthcare grant. And essentially it's looking at, again, trying to shift and support care for people who are living with HIV, who are traditionally cared for in the specialist community, trying to shift that care and understand how the care is delivered across Canada from a primary care perspective. So Claire has done a lot of work connecting into ISIS, and again, very much like Peter was describing, you know, very descriptive sort of phase at the beginning, which was identifying how is care delivered, who are the family doctors or nurse practitioners who are looking after people with HIV, what happens to people, are they identified, what's the treatment like, and doing a bit of a comparison between now the primary care communities and specialty care. We're now into a phase, or have been in a phase, where we're trying to implement solutions. So because I'm the e-consult person, e-consult of course is incorporated into that. Essentially the other piece that is incorporated into that is also linkage to community resources and self-management support for people living with HIV. Kevin Potty brought up before that we have created this clinical scholars program in the Live Innovation Team, which is identifying we have 3 patient partners from across Canada, Manitoba, Newfoundland, Ontario, and they are formally identified as basically community scholars in our program. They get a stipend, they're on the executive, they really are a very, very strong voice in terms of the work and the direction that we're going, and in particular now, highly relevant in terms of our knowledge exchange or knowledge translation. So taking the results of an ISIS study and saying the so what does this mean, and what can we do with it? So Ron now was interviewed. We have a nice website, so I encourage you to take a look at our website. So here's some of the results that we have from that study, is that essentially people living with HIV who receive primary care are more likely to have preventative care if they're looked after, you know, essentially in our practices as compared to specialist care. We have also looked at the different models and have been applying the chronic care model approach and patient-centered medical home model approach to people living with HIV. And we're trying to look at what the similarities are. And the interesting thing with HIV is that it has very much become a chronic condition. And so that is, I think, a very large sort of theme of the program of research that Claire is leading. Also, that ties into aging and what's happening with people who have had this condition, are managing it well, and as they age, there's a lot of complexities to that care. Ultimately, I think I spoke to that. We're looking at now the solutions and have submitted more grants now to actually look at solutions such as e-consult, self-management support, rehab support, and basically also some practical guidelines for people who are living with HIV. And I think I'm going to just leave it there. These are sort of some of the activities that we're coming up on. We're very much into sort of final stages of the 5-year grant, which is about now taking all of our findings and sharing it back to the community, and as I said, informing what are going to be some of our solutions that we think will continue to improve care. All right, I'll leave it at that.
Perfect.
Never seen that. I didn't see that series of slides before, so thank you.
Hey.
easier if you to turn around a bit and have a discussion. So we can pick up a little bit on, see where we were at before, some more thoughts.
I'm just curious about the relevance across Canada. So, for example, the finding that you saw about comparing for doctors, how different was it across provinces? So, availability of family physicians is definitely
Not different.
Really?
3 provinces that we tried to match the regions for similarities. They were in fact very different. Fraser East BC, Eastern Health Region Ontario, rural, semi-rural, small industrial town, and Halifax. And across them all, everybody, whether they themselves, their neighbor, or their parent, is aware that there were shortages of family physicians and it was hard to get them, or nurse practitioners, and that they were lucky to get who they got. And they genuinely, for the most part, were happy. Very few exceptions, unhappiness. And the data is much richer than that. But the real sense that going this comparative doctor shopping route and investing your resources will harm small communities, started to do inequity of burdens to the good doctors, that people aren't that interested in changing if they're fine, so they're not going to be motivated to go to this website. But boy, do they want to know that the community is served as well for primary care as it is for schools. They want that school ranking for primary care for the community.
Just going to quickly follow up on that. I think, like as I hear everyone present, I think the common theme among this group is that we're all based on looking at community-based care. I mean, there's equity themes and there's, underprivileged service, under access, people with no access. But I think for one thing that makes us unique is that we're all focused on post-acute care, and that's it may seem like it's what everyone's doing, but it's not, right? It's very different. Everyone in OHR in the hospital is looking at acute care, hospitals, right? We're looking at, more bench work, right? I think what's really unique to us is that we actually go into the community and ask what the relevant questions are in the community. I think that's really
So I mean, this is primary healthcare,
yeah, exactly.
right? Community and family practices.
And it fits with Bruyère so well because Bruyère is about what happens after you get discharged from the hospital, right?
And home
exactly.
is.
And it's part of the transition.
But it's really about the continuum of services post-acute, right? So, and I think, we've had this real challenge in the system where we constantly are investing in the most expensive care, right? The beds and the emerges and we all know inherently that we should be investing upstream, right? But the system is just not, it's so hard to shift what you have to what you want, what you need and what you want. And we get into these kind of cyclical conversations from a public policy perspective, and they get politicized. But I think that again, going back to if we're going to really kind of own the space that we occupy and really then map out the future, that's a really big piece. And I think it's consistent with what we're talking about at senior leadership about let's not make it like we inherit patients after acute. We actually own this space. We're the bridge to home. And I often characterize it to the public that, the acute care system kind of saved your life. We give you back the quality of life. You're with us longer. We know you better. You're going to probably come back and see us if you know what I mean, for other things, right? So it's that piece but again, it's like people don't even understand who we are. Even our own teams don't really understand or could articulate who we are in the system, right? So we have a big job to do, but I think there's so much great work going on. I was just literally going, okay, I need to get you to come to the board, because people actually people don't really understand all of the great work that PRI is doing.
But I think it's worth it. Thank you, and I'd love for us to go to the board. I think it's worth having another conversation where we kind of have a common thread that we're able to bring to the board. And by the way, I just want to introduce Claire Kendall, who just walked in.
It was an excellent presentation.
Preparation and execution. So it might be worthwhile talking about something like that, where we strategize together with your help, because we've talked about communication for us and how we might communicate what we do, but I think it's worthwhile to sort of align with this helps.
Yeah, so I'll just
sharing that question.
No?
Oh,
Yeah, you go ahead and
okay,
Nicole.
so two things. One thing, to me, the theme is no person left behind, right? I am about the person in my office in the clinic, or who's not at the clinic, or who should be at a better, it's no person left behind, right? And that, I think, that's to me sort of primary care. So it's always about the person. And to me, I feel like campaign-wise, whatever, that would be something that could be, built upon, because you can find the person in palliative care, or the person who has dementia, the person living with HIV, or the person. It's just it sort of creates it and goes across the boundaries. And I think the second thing I'll just leave is that I think there's the opportunity now to not be trying to fit into what was the strategic plan, and I would really challenge Bruyère to blow out the walls, right? So we're not institution-based. That's the whole thing about primary care and community care. It is not institution-based. And so there is no other institution who's doing that, who's thinking about that, who we can own that space. We are well positioned, especially with all of the amazing work that I think the primary care group is doing collectively in this room to essentially grab that space in a way that then also is totally unique and novel for Canada. So it just
Really nicely said. Sharon, Kevin, please. And I think if you ask the providers who work in this system, in the family medicine centers, we feel it every day. We're driven by Bruyère is always there. No matter who you are, whether you have a home or not, where you are in the stage of life, you're always there. And that reflects the different interests that we're doing. But one of our challenges that I think we have to really highlight in the research is it is hard to do research where you are, when you're not at the alcohol hospital with a million other patients and a huge infrastructure. We have to fight to understand and improve the care where you are. And that is, you look at the methods that we're doing, the fights that we have, the challenges. There's also a really compelling message that we are trying to improve care where you are.
And we are one of the strongest, if not the strongest, primary care group in Canada.
We are the strongest primary.
Absolutely, especially
We
for
are
us.
the
But
first.
that's also
That's
the rehab group and
It's so great opportunity. Was it in relation to Sharon? Okay, so Kevin, Marissa, and then David.
I'm a little bit concerned about, like, say, us meeting when we have other researchers at the BRI, and how we could have, like, I wish we could be working better together, and so I don't want to kind of create silos again. The second thing is that, I guess, Peggy, you bring this up, which I don't know if when you say, like, bridge to home, I don't know if you realize what you just said there, but for all of us reacted to this, because that's what a rehab person thinks when they're bridging home, right? As a family medicine, they don't have to ever go to the hospital. We look after people from palliative care. We don't think like that. And I think we have to be careful with that, because that assumes that the hospital has expenses to pay for population. Whereas we actually would say that we're willing to go to them. Like I just heard Claire, I think Sharon even, but I kind of feel like we think we're where you need us. So I just have to be, I'm not trying to be critical of the statement, but I would hope that we can kind of go a step toward that we're more than just a bridge. We're actually wherever they need it.
Yeah, and again, like for me, when I talk about Bruyère, I'm talking about not a place. Like I'm actually talking about, a constellation of services. So, right, because I think, I don't even like to use the word hospital when I talk about Bruyère, right? And I've actually been pushing to actually rename Bruyère so that it's not Bruyère Continuing Care, Bruyère Hospital, or whatever we're not, right? But that we actually come up with, we are like a constellation of services that include, supports to housing, outreach, where you go to people's homes. I really do understand that. And I think that's one of the challenges is that, it's a very complex system, and so it's a complex story to tell, and there's ways that we can do a much better job, but I totally get that, Kevin. And that's why I think we've got this opportunity now to really truly re-envision all of it. And we have a new CEO who really understands that, because he's spent 6 months now trying to figure it all out, and he's like it's so complicated. But he keeps kind of going back to this continuum, right? Like that we are, and that we need to be better at making those connections within the services that we have the oversight for, but also throughout the entire system, you know, we're very connected to the other hospitals, but not necessarily in, you know, really smart ways. And then I look at the work that you're all doing. I mean, you're solving so many kind of system issues, very driven by the needs of your patients. And that's the way the system should be wired, right? But we often talk about it as organizing services and institutions, and we forget that it's all about serving people. So I just feel like there's a really good opportunity, and that the timing of this conversation could be better.
So I'm going to bring up again my clinician teacher's perspective. Just this month, CMAJ, both for McMaster, published the fact that there are less and less medical students are choosing family medicine, and the data was very confirmatory that they learned that in the hospital when where they're getting most of their education. And I think if we are going to be a center of excellence in promoting primary care, we also have to collaborate very closely with the department in order for us to be the ones who, you know, have state-of-art education for our medical students from the perspective of primary care, mentor them, and bring them into the family medicine with the perspective of being primary care and the ones who actually provide the best care to our society, because only 20% of the population is sucking 80% of our healthcare spending in the hospital, and then there's the rest of us delivering that care in the community. So I can't emphasize the importance of collaborating with the department and being innovative in terms of bringing our education value up.
I think that's important. One of the things that we heard recently on MSLT is, I think you guys have one of the largest training family medicine practices.
75 residents per year.
But look into education, it's all for care, that is where you are, whether it's palliative, whether it's preventive, primary.
600 faculty, right?
It's training for care, the kind of care that you want, and there's a message there that our research fits into.
So we've gone over time, but I will let David have the last comment question.
Thank you. So one opportunity that hasn't really yet come up, I'm so happy you're coming tomorrow morning to this event at the Aga Khan, because I think we can have a global impact. We talk about inequities. It's hard to talk about inequities without also thinking about how jurisdictions are becoming less relevant to those inequities. There's lots of migration, and there's lots of lessons that can be applied across jurisdictions. One example, very briefly, I'm involved in writing up some articles comparing Brazil and Canadian healthcare systems. Colleagues are so impressed with European consult service care. They have a huge wait list problem because they cannot legally call patients on the phone. One of the longest waiting lists in the Americas. And so they've really had to come up with great solutions around synchronous consultations on the phone, real time. So we could be learning from this. There's no reason we cannot be applying these lenses across jurisdictions. So that's another opportunity I really wanted to mention.
So can I just say one thing?
By all means, yeah.
I'm really, so thank you so much for taking the time to do these, because I know this isn't normally the path that you guys take at Bruyère, but I really appreciate that. It was really useful for me. I gave Peggy a call just recently to ask if she was free. One of the quiz, and I thought that was really wonderful that she was able to be here, because she also is getting more and more information from what we do here. He sends his regrets. He's out of the city, so he couldn't be here, otherwise he would have been here as well. But primary care is discussed quite often at SLT, and it's clearly really critical to the organization. And so I just wanted to thank you for putting this together today. It was really useful.
And thank you for your
Hopefully you can share
engagement.
and you'll share your slides with us. If that's all right. Thank you.
And we'll continue our discussion.
Yeah, thanks.